السلام عليكم. آسف على التأخير، كان في بس مشكلة في الصوت ومشكلة بس في تعديل السلايدز باش تناسب الابليكيشن. كان المفروض اليوم نغطي معظم الاندوكراين emergencies مهمة، لكن فضلت إنها حتكون المحاضرة هذه جزء من الاندوكراين emergencies، وعلى أساس إن الجزء الآخر ممكن ناخذوه في يوم آخر. إذا قبل لا نبدأ، إذا كان I asked one question. What do you think is the most common endocrine emergency? شنو هي أكثر endocrine emergency we are facing in practice who deserves more attention than others? Any idea? Addisonian crisis is not common. Yes, hypoglycemia. Hypoglycemia is the most common endocrine emergency we see, and for Addisonian crisis, I don't think that we are seeing much even in our endocrine practice, but it's one of the most important because it's difficult to recognize and it's potentially fatal. But if we think what are the endocrine emergencies that we may see in everyday practice, we have the مش عارف، في مشكلة في السلايدز، هتتحرك من عندكم. هذين endocrine emergency that we are seeing in our clinical practice. The diabetic emergencies, the most common endocrine and diabetic emergency is hypoglycemia. We almost see it every day. And diabetic ketoacidosis is the second most common endocrine emergency. So the most common endocrine emergencies are the diabetic emergencies. Hyperosmolar hyperglycemic state is another important endocrine emergencies, but we are not seeing it as common as the DKA or hypoglycemia. Thyroid emergencies for the myxedema coma, it's very rare. We usually see it in rural places than in urban places here in Libya. Thyroid storm is slightly uncommon, but we see it more commonly than myxedema coma. For the adrenal emergencies, we have the adrenal crisis, we have the pheochromocytoma hypertensive emergencies, both of which are not common. Calcium emergencies are common, either severe hypocalcemia or severe hypercalcemia. And we have emergencies that are related to the pituitary, like the pituitary apoplexy, which is pituitary hemorrhage or infarction, and will lead to neurological sequelae as well as endocrine sequelae. And we have the symptomatic hyponatremia. I put it with a pituitary emergency, but it's not always due to pituitary disease. It's usually due to a systemic disease rather than a pituitary disease. In this lecture, I will focus only on the diabetic emergencies, and in the second lecture, we will take the other important emergencies, particularly the thyroid and the calcium emergencies. So starting with the most common endocrine emergency, which is the hypoglycemia. We have to suspect hypoglycemia in any diabetic patient who is presenting with confusion, with behavioral changes, with convulsions, with coma, because it's very common in patients with diabetes. The problem with hypoglycemia, either in patients with diabetes or without diabetes, it's that we have no formal definition on what level of blood glucose we will consider this as hypoglycemia. Usually we take a range between 45 and 50 milligrams per deciliter, and if the patient has blood glucose lower than this level, we define it as hypoglycemia. But in patients with diabetes, we take this level up to 70 milligram. We always say to the patient with diabetes, if you have blood glucose less than 70, that means that you have hypoglycemia and you should either monitor yourself or treat yourself without waiting for symptoms to develop. So there is no threshold below which we agree that this is hypoglycemia. But we have what's called Obel triad, which is a classical definition of hypoglycemia. We define hypoglycemia as definite hypoglycemia if we have a combination of low blood glucose with symptoms of hypoglycemia, and symptoms resolve when we correct the blood glucose. If we have these three criteria, we will be sure that this patient has hypoglycemia. But the problem with Obel triad is that usually depends, it's a retrospective definition, and we have to show that we could reverse the patient's symptoms first before diagnosing him with hypoglycemia, which is not practical in real life. And in this lecture, I will focus on hypoglycemia due to diabetes, hypoglycemia in patients with diabetes. And in patients with diabetes, hypoglycemia usually is not caused by diabetes itself. It's caused by diabetes medications. So if you have a patient with diabetes who's on no treatment, on diet control, for example, he's unlikely to develop hypoglycemia. Hypoglycemia usually occurs in treated diabetics, either because they took too much medications, particularly insulin and sulfonylurea. Insulin and sulfonylurea are the most common causes of hypoglycemia in patients with diabetes. Sometimes the patient has appropriate dose for him or for her, but he or she took insufficient carbohydrate in his diet, or he's exercising too much without modifying his or her dose of anti-hyperglycemic therapy. These are the three most common causes of hypoglycemia in patients with diabetes. Outside diabetes, we have other causes, including drugs, because commonly we see patients who are not diabetic take anti-hyperglycemic drugs, particularly sulfonylurea, to induce hypoglycemia. And there are other drugs that can cause hypoglycemia in patients without diabetes, including ACE inhibitor, including some antipsychotics can also produce hypoglycemia. Outside diabetes, there are also the classical examples of insulinoma and adrenal insufficiency, but we see these conditions very rarely. So the hypoglycemia being the most common endocrine emergency, it's almost exclusively occurs in patients with diabetes who are treated with medications. Now, when hypoglycemia occurs, usually body has some defense mechanisms against hypoglycemia. And the first defense mechanism to prevent the hypoglycemia from harming the body is to decrease endogenous insulin secretion. And if that fails, the body will ask the counter-regulatory hormones, which are the hormones that counteract the action of insulin. In other words, they increase the blood glucose, including glucagon, cortisol, and growth hormone. They are the three typical counter-regulatory hormones. But if these fails, and hypoglycemia will start to occur, and at that point, the body will increase the catecholamines. And the catecholamines has two functions. First, they are also counter-regulatory hormones. They also will try to reverse the hypoglycemia, but the most important function of hypoglycemia to us is that it will alert the body that there is something wrong. That will alert the person that his blood glucose is decreasing. Because the other two mechanisms that occur without the person sensing them, decreased insulin secretion or increased glucagon or cortisol or growth hormone, will not produce any symptoms. But once catecholamines increase in the circulation, they will produce symptoms. And these are the classical symptoms of hypoglycemia or the warning symptoms of hypoglycemia. Hypoglycemia has two sets of symptoms. Symptoms, we call them adrenergic symptoms, which are the result of increased catecholamines, and we have symptoms called neuroglycopenic symptoms, which result from decreasing blood glucose supply to the brain. And usually adrenergic symptoms occurs first to warn the body, to warn the person that his blood glucose is dropping. And these include sweating, palpitations, tremors, anxiety, hunger, tachycardia. They are all activation of autonomic nervous system. And sometimes nausea, sometimes even vomiting will occur. And this is why most patients with hypoglycemia, they can detect hypoglycemia. They can sense hypoglycemia and protect themselves by drinking juice, by taking any glucose-containing fluid. But if these symptoms doesn't occur, or if the patient cannot sense them, or he's not aware of them, he doesn't know that these symptoms are warning of hypoglycemia, after some time, the glucose supply to the brain will decrease, and the patient will have the neuroglycopenic symptoms, like visual changes, like dizziness, lethargy, behavioral changes, seizures, confusion, or even coma. And these are the more serious symptoms. If the patient presents with neuroglycopenic symptoms, that means he has hypoglycemia for some time. And sometimes the patient come with unclear symptoms. Sometimes family bring their father or their mother, claiming that he has some behavioral changes. He's behaving abnormally, although he's completely conscious and he's oriented. So we have to suspect hypoglycemia in any patient with diabetes, especially with diabetes, and have any changes in the mood or behavior or any of these neuroglycopenic symptoms. And management of hypoglycemia will depend at which stage you catch the patient. Usually we divide hypoglycemia to mild, moderate to severe, but the distinction between the three categories is difficult. So usually now we divide it into mild to moderate, in which patient is conscious, whatever the blood glucose is. At this stage, we can give the patient oral glucose. For example, 120 ml of juice. This is usually enough to correct his blood glucose. We have to remeasure blood glucose in 5 to 10 minutes to make sure that his blood glucose is rising. طبعا 120 ملي هذه زي باكو السنتوب الصغير. It's preferable that you don't over-treat the patient. Don't give him more sugar than he needs or she needs. In the same time, we usually advise patients, if you develop hypoglycemia, try to take 120 ml of juice or equivalent. But you will see many patients who are saying that we keep in our pockets chocolate or candy, and we will use them to treat hypoglycemia, which is inappropriate because chocolate contains fat. Fat will delay the absorption of glucose, and he may go into the neuroglycopenic stage before the sugar in the chocolate or the candy is absorbed. So always advise the patient, if you develop hypoglycemia, take glucose in a liquid form. There are some glucose tablets, there are some glucose paste that also can be rapidly absorbed. But glucose that is present in chocolate or in some candies is mixed with fat, and that will delay its absorption. The other stage of hypoglycemia, the other category, is severe hypoglycemia, in which the patient is confused, semi-conscious, or sometimes completely unconscious. And at this stage, you cannot give him oral glucose. We usually prefer oral glucose, but at this stage, you cannot give it. So you have two choices. The first, to give him the glucose intravenously in form of intravenous dextrose, and here we give usually 50 ml of 50% glucose, and we check blood glucose in 5 to 10 minutes, and we assess the patient response. He should regain his consciousness rapidly if it's only hypoglycemia and uncomplicated hypoglycemia. If you cannot get intravenous access, or sometimes at home, because usually patients with type 1 diabetes are at more risk of hypoglycemia, some of them cannot sense the hypoglycemia. Some of them develop hypoglycemia at night. So when the family try to awake him, they'll find him unresponsive. The time that they will take to bring the patient to the hospital can harm the patient's brain. So usually we should give them glucagon in form of intramuscular preparation and ask them to give it intramuscularly once they find their patient is unconscious or hypoglycemic and cannot take oral. And because it will be easy for them to give an intramuscular injection. It's not like the intravenous one. But even in hospital, if you cannot get an intravenous access rapidly, it's preferably to give an intramuscular glucose as soon as possible, because intramuscular glucagon, because glucagon is a counter-regulatory hormone and it will raise blood glucose, sometimes not to the level that to reverse the hypoglycemia completely, but at least to the level to protect the patient's brain from the harmful effects of hypoglycemia. So this is the management of hypoglycemia, which is, as we said, the most common endocrine emergency we face in a practice. If untreated, hypoglycemia has grave complications. First of all, during the attack of hypoglycemia, the patient may aspirate, the patient may injure himself if he develops convulsions or if he falls down. And if prolonged, hypoglycemia will end up with permanent brain damage. We have seen patients who develop hypoglycemia at home and they are brought to hospital 6 or 7 hours after the attack of hypoglycemia. And they are living with permanent brain damage. So we have to educate the patient once we prescribe any anti-hyperglycemic drug that's likely to produce hypoglycemia. We have to educate the patient and the family about the symptoms and the management of hypoglycemia. And if the hypoglycemia recurs, even if it's mild, on the long term, they found that it increases the cardiovascular mortality in patients with diabetes. So we shouldn't ignore mild hypoglycemia, because sometimes we ask the patient, do you develop hypoglycemia? He say, no, yes, I develop it 2-3 times a week, but it's very mild. I can take juice quickly and the symptoms disappear. We have to readjust the treatment, because if the patient continues to have this recurrent attack, he's at risk of cardiovascular disease. So moving to the second most common endocrine emergency, which is the diabetic ketoacidosis. And diabetic ketoacidosis, from its name, is a triad of 3 abnormalities that occur in the body. Sorry for the slides, that's because the application is different from the PowerPoint. First, hyperglycemia, and we usually, some authorities regard hyperglycemia in DKA as more than 150 to 150, and some take it more than 200. I will just stop for the question about if the hypoglycemic patient presents with seizures. Should we manage the seizure with intravenous Valium, which is diazepam, or should we correct hypoglycemia first with intravenous dextrose? It's preferable that you give dextrose as soon as possible. And if that doesn't end the convulsions, despite you corrected the blood glucose, you may give Valium, but usually give priority to giving intravenous dextrose. I want just to mention something about seizures that usually present to the emergency department or develop in the ward. Most of them are self-limited and can end by themselves. We don't need to give intravenous Valium unless we decide that this patient has status epilepticus. We don't give intravenous Valium to any seizure. Most seizures are self-limited and they will end by themselves. Usually we will wait at least for 5 minutes, or if the patient develops any respiratory compromise or hemodynamic instability, otherwise we'll intervene early. But otherwise, most seizures will end by themselves, including those that occur from hypoglycemia. But they will be recurrent unless we correct hypoglycemia. So it's advisable that we correct hypoglycemia first. Back to the DKA, we said it's a triad of 3 abnormalities. Blood glucose of more than 200 to 150, acidosis, either by demonstrating a pH of less than 7.3 or serum bicarbonate of less than 15, and ketosis, which is demonstrated by blood ketones, which is the preferable method to be used in the criteria, of 3 or more millimoles per liters, or urine ketones of more than 2+. If we don't have blood ketones, we can rely on urine ketones, although they are not specific and they are not sensitive. So, usually, and this is the most common, diabetic ketoacidosis is a triad of these 3 abnormalities. But sometimes we have a minority of patients who have ketosis and acidosis, but they don't have hyperglycemia. Their blood glucose is less than 250 or less than 200. And these patients, we call them as having euglycemic DKA. If you have hyperglycemia, but without acidosis or without ketosis, it's not a DKA. So it's some other hyperglycemic emergency or other hyperglycemic crisis than DKA. So to diagnose DKA, we have to have both acidosis and ketosis. So why DKA occurs? Usually DKA occurs in patients with type 1 diabetes, as we all know. But sometimes it occurs also in patients with type 2 diabetes, and we call them as ketosis-prone type 2 diabetes. But classically and commonly, it's a complication of type 1 diabetes. And it results from insulin deficiency, and this insulin deficiency can be absolute, which is more common, or can be relative. And insulin deficiency, when it occurs in conjunction with activation of counter-regulatory hormones, we will have two major sequelae. First, glucose uptake will decrease, and because of decreased glucose uptake from the blood to the cells, in absence of insulin, glucose will accumulate in the circulation, and that will produce hyperglycemia. And because there is no insulin to take that extra glucose into the cell, the body has another mechanism to get rid of the glucose, which is through the renal excretion. So glycosuria will occur, and glucose will be excreted in the urine. But glucose to be excreted in the urine, it has to take some fluid with it. So osmotic diuresis will occur. And this is why the patient will develop polyuria. And because of the loss of the fluid, he will have polydipsia. And the result of this continued excretion of glucose along with a large amount of fluid, the patient will develop dehydration. And a lot of electrolytes will be lost from the body. So the patient will have some electrolyte depletion. Now, this sequelae of insulin deficiency is not unique to DKA. It can occur in any hyperglycemic emergency, even in simple hyperglycemia, even in hyperosmolar hyperglycemic state. So it's not unique to the DKA, but can occur with any hyperglycemic emergency. What is unique to the DKA is the affection of the other function of insulin. We know that insulin has many functions. One of them is the increasing glucose uptake, but also it acts to prevent lipolysis, the breakdown of fatty acids in adipose tissues in the muscles. And in absence of insulin, the lipolysis will increase. The counter-regulatory hormones will try to take more energy substrates from the fatty tissue, and the result of the lipolysis will be increase in free fatty acids and increase in glycerol. And why our body try to increase lipolysis in absence of insulin? Because it senses that there is not enough glucose in the cell, and it will try to synthesize more glucose. So it will need more substrates to produce glucose. So the liver will use glycerol to synthesize glucose in form of gluconeogenesis, but this will be a harmful compensatory mechanism because it will exacerbate the hyperglycemia, and we will have more osmotic diuresis and more dehydration. But the other end product of lipolysis is the formation of the free fatty acids. And free fatty acids include the acetone, include the beta-hydroxybutyric acid, and these are acids in the blood, and these are what we call as ketone bodies. They will be produced from the free fatty acids. The ketone bodies will be produced from the free fatty acids, and they will accumulate in the blood, producing ketonemia. The body will try to get rid of them in the urine, producing ketonuria. But they will be responsible of the acidosis that will occur, and they also will be responsible for increasing electrolyte depletion from the body. So this is the pathophysiology of DKA. The main trigger is insulin deficiency, either absolute or relative, and it will have two major end results: decrease in the glucose uptake that will produce the dehydration, will produce the hyperglycemia, and increase in the fatty tissue breakdown that will produce the ketonemia and ketonuria and will end up with acidosis. Now, why insulin deficiency occur? Just let us look to the how insulin is produced in the body. Insulin is produced in the body in two forms. If you look to this line, we call this basal insulin or background insulin. Throughout the day, pancreas will produce insulin in continuous manner at a set rate, and we call this background or basal insulin. This insulin is very important because it will be secreted irrespective if the patient takes a meal or not. Even in the fasting patient, this insulin is being secreted. The function of this insulin is to prevent the glycogenolysis, gluconeogenesis, and lipolysis. So this background insulin is the insulin that prevents DKA. And with each meal, another insulin is produced, which we call the bolus insulin. Pancreas will produce large amount of insulin if the patient takes a meal. If he takes another meal, it will produce another bolus, and etc. Now, if, for example, a patient with type 1 diabetes usually takes two forms of insulin. He will take bolus insulin with meal, and he will take basal insulin once or twice daily. An example of basal insulin is the MBH, is the glargine or detamir. Examples of the bolus insulin is the regular or plain insulin, the aspart insulin, or Lispro. Now what happens? If the patient with type 1 diabetes gets any illness, becomes sick, unable to eat, what they usually do, they will stop taking all insulin because they think that insulin is for food, and they will stop taking the meal insulin or bolus insulin, and they will stop taking the basal insulin. And that's what will cause the DKA. Most commonly, we see DKA because patient doesn't take his or her basal insulin because of illness, because they think if they will take it without eating, they will develop hypoglycemia, which is not true. The insulin that is prescribed for eating is the bolus insulin. The basal insulin, its function mainly to prevent the glycogenolysis, gluconeogenesis, and lipolysis. In other words, to prevent the DKA. And in illness, we need to increase this basal insulin because in illness, the counter-regulatory hormones are increased. So the patient should increase his or her insulin, not to decrease it. He can stop taking bolus insulin because he will not need them because he is not eating, but he should increase his basal insulin. But what we see in practice, they usually stop taking the basal insulin. So we have to educate them about the importance of taking the basal insulin at all times. Even when they fast Ramadan, usually we keep the basal insulin throughout the day. Otherwise, they will develop DKA. So, the most common precipitating factors of the DKA include conditions that are associated with absolute insulin deficiency and mainly newly diagnosed diabetes. We know that 30% of patients with type 1 diabetes present with DKA. Their first presentation is DKA, and they usually run from clinic to clinic, complaining of non-specific symptoms of abdominal pain, of vomiting, and they are treated as gastritis at some place and treated as some other gastroenteritis and another. And we will take sometimes hours or days before somebody do a blood glucose for them, because they are not known as diabetic and nobody thinks that they might have a DKA. If the patient is known as having type 1 diabetes, it will be easy for us to consider DKA if he or she presents with any of the symptoms suggestive of DKA. The other cause of absolute insulin deficiency is insulin omission. As we have said, during illness, usually patients stop taking insulin, and that will precipitate DKA. And there are causes which produce relative insulin deficiency. The most important of them is infection. During infection, there is a relative insulin deficiency. We should ask patients to increase insulin doses during illness, particularly the basal insulin. Sometimes we ask them to measure blood glucose more frequently, every 2 to 3 hours, and give insulin frequently to prevent the DKA and the ketosis. Any stressful medical illness like stroke or myocardial infarction can precipitate DKA in a patient with diabetes. Steroids are known to precipitate DKA because they are counter-regulatory hormones. They are, when we give them as drugs, as medications, we give them in large, supraphysiological amounts. That's much more than the body secretes. So there will be a strong counter-regulatory counteraction against insulin, and that will result in DKA. And in some patients, we don't know what's the cause. The patient is taking his insulin, he's not having infection, he's not taking any other drug, but he or she presents with DKA. The clinical features of the DKA depend on the pathophysiologic mechanism that we have just demonstrated. The hyperglycemia with the glycosuria will produce the polyuria, the polydipsia, the polyphagia, the weight loss, the fatigability, and the acidosis will produce the nausea and vomiting, abdominal pain, and muscle cramps. And usually the symptoms of DKA develop acutely over less than 24 hours. That differentiate it from other hyperglycemic emergency. The DKA is usually an acute illness. In patients with simple hyperglycemia, usually you will not find nausea and vomiting and abdominal pain in particular, because they are usually symptoms of acidosis. You will find only these symptoms, which suggest that the patient have simple hyperglycemia without acidosis. So how we diagnose DKA? We mentioned it in the first slide about DKA, about the triad of the DKA. We can diagnose DKA if we have the three criteria. If we have blood glucose of more than 200, if we have pH of less than 7.3, arterial pH of less than 7.3, and serum bicarb of less than 15. But in practice, we don't need arterial pH. You can take venous pH because it's not different from the arterial pH. And it's much easier to take it. It's much easier to repeat it again during the monitoring. But in the formal criteria, they mention arterial pH. But in practice, it's enough to take venous pH. You take arterial pH only if you need arterial blood gases with it. If you think that the patient has some respiratory compromise, he may have hypoxia or hypercapnia, which are different. The partial pressure of oxygen and CO2 are different between arterial and venous blood. But the pH and bicarb are not different. They are the same in venous and arterial blood. And we usually in DKA demonstrate that there is an increased anion gap. And the anion gap is calculated by subtracting the chloride and bicarb from sodium. And if it's more than 15 millimole, we call it increased anion gap metabolic acidosis, which is typical of DKA, which means that there is some unmeasured anion, which are the acids that increase the gap. We don't usually calculate it in practice unless we suspect that it's not a pure DKA, it's something else with DKA. So what's the differential diagnosis of DKA? Of course, other hyperglycemic emergencies, other diabetic emergencies, severe hyperglycemia. Usually, sometimes we treat patients at DKA in hospital when they have only severe hyperglycemia, simple hyperglycemia that's not complicated by acidosis. And if we have no access to measuring the pH or serum bicarb, we assume that the patient has DKA until proven otherwise. The osmolar hyperglycemic state, which occurs only in type 2. We don't see it in type 1. So if the patient has type 2 diabetes, we may put this in differential diagnosis. Lactic acidosis, where there is hyperglycemia and acidosis, but there is no ketosis. And sometimes the other causes of high anion gap metabolic acidosis, like starvation or alcoholic ketoacidosis, like poisoning with salicylate or ethylene glycol, or renal failure. Moving to the management of DKA, we have, just to take what investigation usually we will order. Blood glucose, plasma bicarb, arterial blood gases. We know that we ask for these investigations to diagnose the DKA, to confirm that it is DKA. We take plasma ketones or urinary ketones. We should measure urea and electrolyte, particularly potassium. Potassium is very important in DKA. Because of acidosis, potassium will be shifted from intracellular fluid to extracellular fluid. And the patient might present with hyperkalemia. Although the total body potassium is depleted. From the slide of pathophysiology, we mentioned that there is electrolyte depletion. The most important electrolyte depletion that occurs in DKA is the potassium depletion. But at presentation, because of acidosis, the serum potassium is high, but the total body potassium is low. And during management, potassium will move back from extracellular fluid to intracellular fluid. And the real reflection of total body potassium will occur, which is hypokalemia. So it's very important to measure potassium before starting management of DKA. The other investigation like ECG, chest X-ray, CBC, blood and urine culture sensitivity depends on the patient. If we have a patient with DKA that admits omitting insulin, there is no need to ask for this investigation because we know what precipitated DKA. But if we are not sure of what precipitated DKA, we might ask for chest X-ray, CBC, blood and urine culture to look for any infection that might precipitate it. In older patient, we might ask for an ECG to rule out an acute coronary event. But usually we don't need them in most patients. The treatment of DKA. DKA is a medical emergency. We should start treatment as soon as possible. And we should treat patients with DKA preferably in an intensive care unit or in a high dependency unit. Because we cannot rely on facilities in the ward to monitor the patient with DKA. Patients with DKA need frequent monitoring, particularly in the first 6 hours of treatment, which cannot be provided in the ward. And the principles of treatment include fluid replacement, insulin treatment, electrolyte repletion, and searching and treating the underlying precipitant. If there is an evidence of infection, we should treat it. If there is an acute myocardial infarction, you should treat it. This is different from patient to patient, but the common principles are the first three, which I will discuss briefly in the following slides. Regarding fluid replacement, in DKA there is an average fluid loss of about 100 ml per kg. That's an average 6 liters per fluid are lost from the body in patients with DKA. And we have to replace these fluids to correct this dehydration. And usually we correct it initially with normal saline, 0.9% sodium chloride. And this is the schedule that we usually use to correct this deficit. 1 liter over 30 minutes, 1 liter over 1 hour, 1 liter over 2 hours, then 1 liter over 4 hours, then 1 liter over 6 hours. But this is only a guide, and we have to modify this rate according to the patient. For example, if we have a patient who presented in shock, in very low blood pressure, we should ignore this guide. We should give fluids as rapidly as we can to correct the hemodynamic instability first, and then we will focus on the deficits that need corrections. If we are faced with an older patient, we may be more cautious than this rate. We may give a slower rate, a less amount of fluid, to make sure that the patient doesn't develop volume overload. So this is only a guide, and we modify it according to the situation, according to the patient. And we will continue giving the normal saline until we get blood glucose at less than 250 or less than 200, and then switch it into 5% dextrose to prevent hypoglycemia. And in some places we may give also 10% dextrose, because the function of the fluid is to correct dehydration, but also the fluid therapy will reduce the hyperglycemia, even if we don't give insulin. But because we are giving insulin at the same time, the blood glucose will fall, and fluid doesn't correct acidosis. Usually insulin is the intervention that will correct acidosis. So sometimes we correct dehydration by fluids, but the acidosis is still there. So we have to continue giving insulin. And sometimes blood glucose will fall to less than 200 and the acidosis is still there. So we have to continue insulin. And if we continue insulin, blood glucose will continue falling. So at this stage, we may give even 10% dextrose to prevent blood glucose from falling into a hypoglycemic range, because this is a very common complication of DKA treatment, the hypoglycemia. The other arm of treatment is the insulin therapy, and the insulin is very important to correct acidosis. But we should remember one point, that we shouldn't start insulin unless we know what is the potassium of the patient. Because if we give insulin in a patient who is hypokalemic, we will definitely kill him. Because insulin will move potassium from outside the cell into inside the cell, will move the potassium from the blood into the cell. And if he's hypokalemic, he will be more severely hypokalemic, and it might kill the patient. So we should first check the potassium before giving insulin. We can't give the fluid immediately, but we should wait until we get a result of potassium before giving insulin. And usually there is no need of bolus dose. We can start the infusion immediately. We put 50% units of regular insulin in 50 ml of normal saline, and we calculate the rate at 0.1 unit, which is equal to ml, because we put 50 unit in 50 ml. So each 0.1 unit, it's equal to 0.1 ml per kg per hour. If we calculate it to 70 kilogram person, it will be 7 units per hour. This is the average rate. So if we can start this infusion quickly, there is no need to give a bolus dose. But if there is a problem in setting up the infusion, we might give a bolus dose of 7 units until the infusion is ready. And we will continue this rate, the 7 units per hour, until the blood glucose is less than 250. And at this stage, we may reduce insulin to 3 to 4 units per hour. And we should continue insulin until we have evidence that acidosis has been cleared, until we have pH above a certain level and the bicarb above a certain level, and the ketones are cleared from the blood. At this stage, we may stop insulin. In some places, they don't decrease insulin at all. When they start insulin at 7 units, they will continue it throughout the management. And when blood glucose falls below 250, they will give him more glucose. They will give him 10% or sometimes higher concentration of intravenous dextrose to keep blood glucose away from the hypoglycemic range. And this will allow insulin to more efficiently clearing the acidosis. And when acidosis resolves and the patient is able to eat and drink, we can start subcutaneous insulin and stop the infusion. Otherwise, we have to continue infusion until acidosis resolves completely. The third arm of the management is electrolyte repletion, and we mean potassium. And as we have said, that total body potassium is depleted in DKA, but usually initially potassium is high. There is hyperkalemia because of the shift of potassium from the intracellular compartment to extracellular compartment, and because of the dehydration and the contraction of the extracellular fluid. But if the patient has severe DKA, if the patient is having the DKA for some hours, sometimes some days, he might present with hypokalemia instead of hyperkalemia. This is why we have to check potassium before starting insulin. Because as therapy started, potassium will start to fall, and we will need potassium replacement even if the patient initially presents with hyperkalemia, because the principle is total body potassium is depleted. So how we will give potassium? It depends on the measured potassium. If we have high potassium at presentation more than 5.5, we shouldn't give potassium. We should wait and we should monitor the potassium levels. If the potassium levels are in the normal range, we will give 20 to 30 millimoles of KCl with each liter of fluid that we are giving to correct the dehydration. And if the potassium is in the hypokalemic range, we should give 40 millimoles per liter or sometimes per hour. And at this stage, it's preferable if during management potassium falls to less than 3.5 and particularly to less than 3, we should stop insulin. We should stop insulin until we correct potassium, and then we will resume insulin. So this is the three principles of DKA. We should give fluids in form of normal saline. The fluids will correct the hyperglycemia, will correct the dehydration. And we will give insulin in form of continuous intravenous infusion, and the potassium is the main treatment for acidosis, and it will also correct the hyperglycemia. And we should watch the potassium and give it if it falls below a certain level. Now, during therapy, we should monitor the patient. And preferably the first 6 hours, we should monitor the patient every hour with blood glucose, with serum potassium, with pH, bicarb. We should monitor his vital signs, blood pressure and pulse, and we should monitor his urine output to make sure that his kidney is functioning. Otherwise, we may need to for example, to measure his central venous pressure to make sure why he's not excreting any urine. Now, during management, when we do this monitoring, the aim of monitoring is to assess the patient response to therapy. We should have some degree of response to say that our treatment is effective. And this is judged by the hourly fall in blood ketones if we have them. If we have blood ketones, they should fall by 0.5 millimole per liter per hour. So each hour, blood ketones should fall by 0.5. If we don't have blood ketones, we may rely on either bicarb or blood glucose. And bicarb should increase by 3 millimoles per hour, and blood glucose should fall by 50 to 75 milligrams per deciliter per hour. Now, if we don't achieve these targets every hour, that means we have to modify treatment. We have to increase insulin infusion, at least by 1 unit per hour. For example, if we started at the first hour at 7 units per hour, and we come to the second hour and find the blood ketones are not falling, or the bicarb are not increasing, we have to increase the insulin rate to 8 units per hour. And we might continue increasing until we get a response. The most common cause of no response, they found that the most common cause of failure to achieve adequate response to DKA is a faulty infusion pump or a faulty connections. So if after 1 hour or 2 hours you find no improvement, you have to check the lines, because this is what they found the most important cause of inadequate response. If you are giving insulin correctly, this dose should be enough to achieve this response. Now we might do some additional measures. They are not essential lines of treatment, but they are important, and we should consider it in each patient if he or she needs them. For example, the most important issue is the bicarbonate. Now, most guidelines advise against giving bicarbonate. So try to avoid them and don't give them. The only indication might be a severely acidotic patient with pH less than 7. But even in very severe acidosis with pH level of 6.8 or 6.9, the acidosis can be corrected by insulin alone without need of bicarbonate therapy. Bicarbonate therapy has a lot of complications. It will increase the risk of cerebral edema. It will increase the risk of hypokalemia. So we usually try to avoid them. If the patient is anuric or oliguric for 2 to 3 hours after fluid intake, we should do a catheterization to make sure that there is no obstruction. If he's unconscious, it's better to insert a nasogastric tube to evacuate the gastric content and prevent aspiration. We might need even to intubate him or her if unconscious. And if the patient is shocked or has cardiac or renal failure, we might need a central venous line, because at this in this situation, we have to measure fluid intake carefully. We need a central venous line before giving fluid, because we have to give up to 6 liters, sometimes over 12 hours or 18 hours. And this might be harmful to patients with cardiac or renal impairment if not given under central venous pressure monitoring. Sometimes we consider heparin if patients comatose or obese or elderly, because they might be at risk of thromboembolism, and we might give antibiotic if infection is present or we suspect it to be present. If we don't have any clear precipitating factor, we should consider it as an infection until proven otherwise. So lastly, the complication of DKA. The most common complications we see with DKA are complications of treatment, either hypoglycemia or hypokalemia. This is in adults. Cerebral edema is the most common complication in children. So the first two are the most common complications seen in adult and pediatric age groups. Thromboembolism can occur in patients with DKA, acute respiratory distress syndrome, and aspiration pneumonia. But the most common, as I've said, are the complications of the treatment. Mortality is between 5 to 10%, and it's mainly due to cerebral edema in adolescent and pediatric age, because this is the age group that's more likely to develop DKA. But in adults, the most common cause of death is hypokalemia. And mortality now in most of developed world is less than 5%. But still we have here in Libya or in many developing countries a mortality that's ranging between 5 to 10%. And it's usually from an improper management, particularly inadequate fluid replacement or inappropriate electrolyte. So this is about DKA. Let us move to the last complication. I will discuss it only briefly because it's not as common as DKA or hypoglycemia. The hyperosmolar hyperglycemic state. Previously we called it as hyperosmolar non-ketotic hyperglycemia or non-ketotic coma. We used to call it honk. But now the preferred nomenclature is hyperosmolar hyperglycemic state, which is a combination of severe hyperglycemia and dehydration. There is no acidosis. There is no ketosis. And usually there is no absolute insulin deficiency. There is only relative insulin deficiency coupled with increase in counter-regulatory hormone. And it typically occurs in patients with type 2 diabetes. We don't see it in patients with type 1 diabetes. And this dehydration is usually very severe, resulting from the osmotic diuresis, because the hyperglycemia itself is severe. Now, what precipitates hyperosmolar hyperglycemic state? The commonest scenario is an elderly patient with type 2 diabetes who is not taking his or her treatment, either oral hypoglycemic drugs or insulin if he is on insulin. So most common precipitant is non-compliance with the drugs. But it can occur with infection, like the DKA, can occur with myocardial infarction or stroke, because these will increase the counter-regulatory hormones and produce a state of relative insulin deficiency. Drugs, steroids, atypical antipsychotic like olanzapine or clozapine, thiazides, phenytoin, furosemide, all these drugs are known to precipitate hyperosmolar hyperglycemic state in patients with type 2 diabetes. But even with the drugs or with infection, we usually have some element of non-compliance. Either the patient decreasing their medication or they are not compliant at all with taking their drugs. So this is the most important precipitating factor in hyperosmolar hyperglycemic state. Now, how the patient presents. Now, unlike DKA, this is not an acute condition. It usually takes days to develop. So the patient usually will have symptoms for days of ill health, of malaise, of feeling unwell. And he usually comes to our attention only when he developed altered consciousness, become confused, or even develop coma. And when we examine them, we will find signs of dehydration. So the typical patient is patient with type 2 diabetes, not taking his medication, usually an elderly, presenting with few days of malaise, feeling unwell, and when we examine him, we'll find him with depressed consciousness and having signs of dehydration. Now, if we order investigation for such a patient, we will find a severe hyperglycemia. Usually the hyperglycemia is more than 600, and sometimes reaching even 1000 or more, which is not usual in DKA. Usually DKA, the level is between 500 to 600, but in hyperosmolar hyperglycemic state, usually we have very high readings of blood glucose. And characteristically, we have high serum osmolality, and we calculate serum osmolality from this equation. Sodium plus potassium multiplied by 2, plus glucose divided by 18, plus blood urea nitrogen divided by 3. If the result of this equation is more than 320, that means that the patient has high serum osmolality. And this is a result of severe dehydration. But we don't find acidosis, we don't find ketonemia or ketonuria. And potassium, total body potassium in hyperosmolar hyperglycemic state is depleted, like in DKA. But because there is no acidosis, usually we will find the potassium in the normal range. Sometimes we will see some degree of hypokalemia, but the potassium abnormality are not as common as in DKA. The management is similar to DKA. The 3 lines of management, the fluid, insulin, and potassium, we do them also in hyperosmolar hyperglycemic state, but with some minor modifications. First, the fluid replacement, the deficit is larger. Usually they lose up to 9 to 10 liters. So we have to correct larger amount of fluid than in DKA. But at this stage, in this condition, we might we might need CVP monitoring, central venous pressure monitoring, because the patient is usually elderly, not young like in DKA. And the type of fluid is normal saline or half normal saline if hypernatremic. If the sodium is more than 150 or 155, we might need to use half normal saline instead of normal saline. And we can use the same guidelines of fluid replacement as in DKA. We give 1 liter over half an hour, 1 liter over 1 hour, and etc. The insulin therapy is same as DKA. Usually we give the same rate, but because they are not acidotic, they will be very sensitive to insulin. So blood glucose will fall more rapidly than with DKA. So we need to monitor blood glucose more cautiously because the patient are at more risk of hypoglycemia than DKA. This is because there is no acidosis. In DKA, acidosis consumes a large amount of the insulin that we give. So the fall in blood glucose is not as marked as in hyperosmolar hyperglycemic state. And the potassium, we have to give maintenance therapy to prevent hypokalemia in the same manner that we do for DKA. But the thing that is usually we have to do in hyperosmolar hyperglycemic coma is giving prophylactic subcutaneous heparin. And we usually give it to all patients, not like in DKA. In DKA, we assess the patient if he or she at risk of thromboembolism or not. But because of severe dehydration, because the dehydration is more severe in HHS, in hyperosmolar hyperglycemic state, there is a higher risk of thromboembolism. So we have to give prophylactic heparin. Lastly, the complications of HHS, they are somewhat similar to the DKA. But the most important thing that the mortality is very high because it usually occurs in more sick or more elderly patients with more comorbid conditions. So the mortality can reach up to 50% despite treatment. And the other complications are similar as DKA, but we see cerebral edema much less common, and the venous thromboembolism more frequently than we see in DKA. But as a whole, it's not as a common condition as DKA. The management principles are similar, although the patient usually is different from the patient in terms of characteristics, in terms of age, of underlying comorbid conditions from that of DKA, that necessitates that we have to modify treatment sometimes in these patients. So this is the last slide. Thank you for your attention. And if you have any question, I will be more happy to answer. شكرا دكتور سفيان. I thought diabetic emergencies are more common than other endocrine emergencies, and if we gave them all in one talk, it will be very difficult. So in the second part, maybe the next week, we may discuss the other endocrine emergencies that are important, particularly thyroid, adrenal, and calcium emergencies. Look, Dr. Sufyan asked about about peripheral giving potassium in terms of peripheral is it different from into central or peripheral lines? This is a very important question because if we have to give very high concentrations of potassium at a more rapid rate, we have to give it through the central line, because at the central line we can give large amount of potassium. The safest is up to 40 millimoles per liter. If we reach at 40 millimoles per hour, it's preferable that we give it through the central line. You will find many protocols. You will find many guidelines. Some authorities do not prefer that you will give more than 20 millimoles through the peripheral line, but some authorities said you can give up to 40 millimoles through peripheral line. If you exceed that, give it through the central line. Some regard the 40 millimole as the maximum even for the central line, but some can usually give even 80 millimoles through the central line. But if we decide to be safe, we will take the 40 as the 40 millimoles per hour as the maximum rate that we will give through either central or peripheral line, preferably through the central line. Yeah, if I cannot get ABG and found the symptoms of DKA, can I start management? This usual scenario we will face in our hospital. We cannot get blood gases, even venous blood gases. I assume that it's not a problem with the access to the artery, but to access to the machine. Because if it's difficult to get an arterial blood sample, we don't need to get an arterial blood sample. It's enough to get a venous blood sample. But if the problem is with the machine, that we don't have the ABG analyzer in the hospital, and we suspect that it is DKA, we should start management. It will be no harm, because there's nothing more or less we give in management of severe hyperglycemia and DKA. If we see the HS, we give almost the same management without proving that there is an acidosis. The problem will be when we will stop the management. Okay, you can start treatment presuming it's DKA, but at which point you will stop insulin infusion, for example. If you rely on symptoms, this will not be accurate. So to start a treatment, you can take the whole picture into account. A patient who's type 1, who's missing his insulin, abdominal pain, polyuria, polydipsia, high blood glucose, even without ABG, this is a DKA until proven otherwise, so we will treat as a DKA. But when we will stop your treatment, if the patient's symptoms resolve, we don't rely on symptoms. At this stage, we might rely on blood glucose. If blood glucose drops less than 200, we will assume that DKA resolved if the patient's symptoms resolve. But this is not accurate. So to start the treatment is not a problem. The problem will be at what stage we will stop the treatment if we don't have an arterial blood gas. And this is what we will see in our practice, because we see many cases of rebound DKA because we stop the treatment based on symptoms because we don't have ABG. Even if we have ABG, we have it only at diagnosis, and the patient presents at 11 in the morning, and we prove he or she has DKA by ABG, and we start management. But in the evening or the night, we cannot send ABG outside, but his blood glucose is okay. He is not symptomatic anymore. We usually stop insulin infusion and put him on sliding scale or fixed insulin dose to discover in the next morning that he's developing DKA again. So it's not a problem with starting management. The problem was ending the management. No, I prefer not to start insulin at all. For the question, there's a question about if we don't have electrolyte health, if we don't have serum electrolyte, if we don't have result of serum potassium, it's preferable that you don't start insulin. You can get serum potassium even in private lab. You can wait for it even 3-4 hours. Don't start insulin. This will be harmful. It will be very harmful if you start insulin and the patient is hypokalemic. we have seen many patients who develop even ventricular arrhythmia because the treating doctor started insulin with the fluid without waiting for serum potassium, and this can be fatal. So it's preferable to wait for serum potassium. I think I lost just the. Yeah, the fluid you should start at immediately. You can start fluid immediately, and you don't need any investigation to start the fluid. Just assess the patient status. If the patient is not volume overloaded, you can give potassium. You can give potassium. You can give fluid immediately, and you can depend on fluid for management until you get a result of serum potassium. At this stage, you can start insulin when you are sure about the level of potassium. If a patient came to us without diagnosis of diabetes, how we recognize the patient? First thing, to local general examination, except dehydration. If you have a patient who coming with symptoms of abdominal pain or vomiting, and he's not non-diabetic, one of the workup of this presentation in DKA is to check blood glucose. But the clues that you might have from the examination is the increase in the frequency and depth of respiration, which called it the acidotic breathing or osmal breathing. And sometimes patient or family bring the patient or bring their son or daughter saying that he's dyspneic. And sometimes I saw patients with DKA who are investigated for dyspnea before the investigating physician discovered that the patient actually has DKA, has acidosis, not actual dyspnea from respiratory or cardiovascular disease. So osmal breathing, acetone smell sometimes is very clear in some patients, but not all. So these are the signs that can point to a possible DKA. But in general, especially in pediatric, if any pediatric patient presents to you with non-specific signs or symptoms of abdominal pain, illness, which is not clear, one of the investigations that we usually do in assessing these patients is to do a random blood glucose, and this is global glucometer, should be a bedside and done quickly. Dr. Sufyan, there's two questions. One about the pathophysiology of cerebral edema and DKA, the other about the different types of insulin that you mentioned in the lecture. I will take the easier one first, which is the second. Different types of insulin. We divide insulin into two more types according to the pathophysiology we usually see. As we have said, that insulin is produced in two forms: in basal rate, which is continuous, and in bolus rate, which is meal-based. So insulins that available insulins, we categorize them either as basal insulins or bolus insulin. Basal insulins are the longer acting insulin that the patient injects them once or twice daily to produce a basal rate throughout the day. and these include the MBH, the Levemir, the Detemir, and the Glargine. And there's a newer one, which is called Digludec. These are the 4 currently licensed basal insulins. The patient can inject them once or twice. For the MBH, for the Glargine, for the Detemir, they are injected either once or twice. For the Digludec, it's injected once. And we have bolus insulins, and bolus insulins are given with meals. And we have the regular or plain insulin, which is the most commonly used here. We have the Lispro, we have the Aspart, we have the Glulicine. The regular is called short-acting insulin because its duration of action is only up to 6 hours. We will compare it with longer-acting insulin. The Lispro, Aspart, and Glulicine are called rapid-acting insulin because they act rapidly. When you inject them, they will start functioning within 5 to 15 minutes. Regular, it takes up to 30 minutes to start its action. So regular is called short-acting, the others are called rapid-acting. But all of them are bolus insulin, meaning that we give them with meals. So this is the 2 broad categories of insulins. There are types of insulin called premixed insulin, which contains both bolus and basal. They are preparations that contain a basal insulin plus a bolus insulin. The most common one we use here is what we call Mixtard, which is a mixture of MBH and regular. And we have another mixture which is between Aspart and some insulin similar to MBH, but it's not MBH, called neutral glutamine Aspart, in a combination called Novomix. But we call them premixed insulin. So there are 3 types: bolus, basal, and premixed insulin. Premixed insulin, meaning we give both bolus and basal in the same shot. There's a question about sweating. It's one of the earliest symptoms. You mean of DKA? No, it's not a common symptom of DKA. It's a common symptom of hypoglycemia. But usually you don't see it with DKA regarding the sweating. Back to the question, the difficult question of Dr. Sufyan about cerebral edema. Still, until now, there is no conclusion about what causes cerebral edema in DKA. But there is, a DKA is a condition of hypertonicity plus hypotonicity. When we treat it, means that the patient develop mini osmotic abnormality. So there is some imbalance or disequilibrium between tonicity in the brain and tonicity in the blood, which lead to inappropriate movement of fluid into the brain. And this will become more profound if we give more fluid. If we give over hydration, the patient will be hypotonic, and the fluid will move from the plasma into the brain. And this is exacerbated when we give bicarbonate. But the exact pathophysiology is not still known. Yeah, I don't understand by 7 and 8, Dr. Sufyan. What do you mean? Do you mean by 7 and 8? Ah, okay, sorry. So, if there's any more questions? Thank you all. Yes, hopefully. Possibly we will have the endocrine emergencies next week. I will arrange with Dr. Arab first before he announces. Do we have another question? Dr. Sarah, there's okay. Thank you all for your attention, and نتمنى تكون كانت المحاضرة واضحة وما كانش فيها تعقيد.